Good evening, all. I am Dr. Neha Singh, moderator for today's journal journey. I am also editor of Raigad IP as well as joint secretary AHA Raigad, and my co-moderator is Dr. Chitra Kulkarni ma'am. She is past West Vice President IIP Raigad 2022 and President Raigad AHA 2023-24. Now I hand over to Dr. Chitra Kulkarni ma'am for the further proceedings, and welcome.
Thank you, Dr. Neha, for the warm introduction. And we are part and parcel of Journal Journey since inception. Good evening, all the esteemed guests and respected dignitaries. We all have just updated our high funda academics from Pedicon 24 Kochi. Excellent conference and refreshing to our senses from God's own country. Now again, back to our practice and back to basics for general pediatrics. Points which will help us in our day-to-day practice. We are fortunate to have an extremely talented girl, editor of Raigad IIP, Dr. Neha Singh, as moderator for today's episode of Journal Journey, which is run by Maha IIP with Raigad IIP. Over to Dr. Neha.
Thank you so much, Chitra ma'am. Good evening, all. I welcome all the respected dignitaries, seniors, friends who have joined through our Zoom as well as YouTube Live. Dear friends, please note today's journal journey has been allotted 1 MMC points. So please type your name, city, MMC number and central IP number in the chat box. Today, I'm extremely delighted to welcome the dignitaries from Central IIP and Maha IIP for today's journal journey. I welcome Secretary General Central IIP, Dr. Yogesh Parekh sir, also Dr. Shantanu Dev sir, who is Central IIP Vice President East Zone, and I welcome Dr. Ram Gopal Chiraza sir, who is Maha IIP President. Welcome Amol Pawar sir, who is Secretary General as well as EB Central IIP. Dr. Jitendra Gavane sir, who is also Central IIP EB member, and immediate past President Dr. Hemant Gangulia sir, Vikas More sir, President IIP Raigad, and all my friends for today's program. Now I hand over to Dr. Ram Gopal Chiraza sir for the welcome message. Over to you, sir.
Good evening. Anyway, Dr. Neha, it is Chejara, it's not Cherja.
I was to tell you.
Ram Gopal is enough.
I'm extremely sorry.
So I think you can just call me by my first name. So
yes.
Good evening, everyone. Respected chief guest, Dr. Yogesh Parekh sir, welcome. And our guest of honor, Dr. Shantanu Dev, welcome, sir. And respected experts for today's session, Dr. Bharat Agarwal and Dr. Sandeep Kadam. I welcome them. And today's speaker, Dr. Lisa Bulsara and Dr. Sonal Gule. All the best. I congratulate to the Raigad IIP and Chitra Kulkarni madam for a wonderful and interesting topic for today's talk. The risk of hematological malignancies from CT radiations exposure in children, adolescent and young adult. And the second topic is also very good, that is neonatal resuscitation. So for that, the whole Raigad IIP, Neha and Chitra Kulkarni madam, congratulations. Once again, thanks everyone. And now again I hand over to Neha Singh.
Thank you so much, sir. Now I request Secretary General Amol Pawar sir to give his welcome speech. Over to you, sir.
Thank you, Dr. Neha. Since last 2.5 years, this journal journey is going on. And first it was only internal affairs of Raigad IIP team, but now since 2 years, Maharashtra IIB has been taken into consideration for association of the journal journey. And Dr. Hemant Gangulia, Dr. Jay Bhandarkar sir, Dr. Chitra Kulkarni ma'am, Dr. Neha, and above all, the teacher of teachers, the Professor Emeritus, Dr. Mohanty sir, has been the guiding force behind the journal journey along with all the members of Raigad IIP team. Last 2 years, it has been wonderful journey along with means involving all the branches of Maharashtra IIP, and many young and senior presenters were introduced in this journal journey to present various articles designed and guided by Dr. Niman Mohanty sir and team. There are various experts have been involved to guide these presenters also. So this year also, under the presidency of Dr. Ram Gopal Chezara, he has consented Raigad IIP to take the journal journey along with Maha IIP. So I again welcome, I forgot to welcome in the initial phase, I welcome Secretary General National IIP Yogesh Parikh sir, who has consented to be as a chief guest for today's webinar. Then Vice President East Zone, Dr. Santanu Dev, today's guest of honor. Welcome both of you, sir. Maharashtra IIP is fortunate to have you both on this platform of journal journey. So without wasting time, I hand over to Neha Singh. Neha, please.
Thank you so much, Amol sir. Now I request Yogesh Parikh sir to give his blessings. Over to you, sir.
Thank you, Dr. Neha Singh and Dr. Amol Pawar, for inviting me. This is nice to see the Maha IIP and the Raigad branch. So I think since COVID time, this webinar is going on regularly. And second or third time I am invited as a guest or guest of honor. Thank you, Amol, being a secretary, and Ram Gopal ji Chezara. Ram Gopal ji is correct?
It's a Chezara, sir.
So, and my
Sir, Chezara.
Chezara.
Yes.
Yes,
Sir,
okay.
yes.
So, thank you. And my dear Shantanu Dev, Vice President, East Zone, and Chitra Madam, Dr. Neha Singh, Hemant Gogalia sir, and Dr. Sandeep Kadam, Dr. Sonal Guleji, Priyanka Jha, and many more. So thank you very much for inviting, and heartiest congratulations to continue this journey after the COVID period also. And one more point I have noticed that every time you have NMC credit hours, and so large number of the participants, even after the COVID, on the virtual platform. So this is the beauty of this Maha IIP program. My dear Dr. Jitendra ji, always dynamic member or EB member from the Maharashtra, working on the national front, along with the Amol and everyone. So thank you very much. Actually, I have to join Amol. I have consented in the afternoon, but after that, one meeting is planned just now. So I have one meeting, so I'm going there, attend the IIP meeting. Thank you very much. Best wishes and keep learning, happy learning. My regard to Bharat Agarwal sir and Mohanty sir and everyone. Thank you.
Thank you so much, Yogesh sir, for your blessings. Now I request Dr. Shantanu Dev sir to give his blessings.
My warm regards and greetings from East Zone to all of you, the office bearers of Raigad IIP and the office bearers of Maha IIP. Dr. Ram Gopal sir and Dr. Amol Pawar, my friend, and I can also say Dr. Jitendra Gavane, Dr. Hemant Gangulia. Thank you all for calling me here to be a guest of honor. It is a proud privilege and an honor for me also. In fact, this is probably my second or third meeting where I have come as a guest, and I have thoroughly enjoyed my previous sessions with all of you also. My regards to the experts, Dr. Bharat Agarwal and Dr. Sandeep Kadam, and my best wishes to the presenters. So I hope, and I'm also very intrigued to, my video will be off, but I'll be listening to their talks because recently in Pedicon, I was asked to give a lecture on recent or the updates in the CPR guidelines, pediatric CPR guidelines. And from the audience, there were 1 or 2 questions on NRP guidelines. So I am so happy that I hope that they'll be attending these talks today also. And I am intrigued to hear the name of Dr. Niman Mohanty because he belonged to his zone once upon a time. How come he has gone to Raigad? I am not very sure. Because when we were postgraduate students, Dr. Mohanty was at that time, he was working in Guwahati. In fact, the city where I was also doing my post-graduation. And I am so happy to hear his name again today. I wish all of you the very best and thank you for inviting me.
We'll be
Thank you,
catching you in next few months, sir.
Okay.
So may I say something? Dr. Neha,
Yes.
may I say something?
Yes,
Dr.
sir.
Shantanu, Dr. Nimen Mohanty, this was a conceptualized by Dr. Nimen Mohanty, sir, myself and
Okay.
Dr. Jay Bhandarkar to start. And he is at present Professor Emeritus at MGM Navi Mumbai College, which is
जीतू
South
जीतू
Center
भाई के
actually
पास है
Raigad.
All right.
So
So nice
Center
to hear.
Raigad.
जीतू
And Shantanu sir, as well as
Yeah.
Dr. Yogesh Parikh sir, Dr. Amol said it was internal affairs of Raigad, but in next 2 years it became the external affairs with other 3 states also, Gujarat and Telangana and Goa. And I presume in this year, with help of Dr. Amol sir and Dr. Ram Gopal sir, with Yogesh Parikh sir and this Shantanu Dev, we will move towards East Zone also and Central Zone also and West Zone also for making
Yes.
the external affairs of this general journey. Thank you. Sorry to
Good.
intervene.
Yeah, sir, Dr. Nimen Mohanty sir was here, but because of some family emergency, he has not joined.
Okay.
But he is our main mentor for this journal journey.
Okay. Very nice to hear about
Thank
that.
you, sir.
सर डॉक्टर जितेंद्र इज देयर ना सो सर का ब्रेक आ जाएगा
Thank you so much, sir. Now,
डॉक्टर नेहा
I
may I leave? Dr. Neha, may I leave? I have to
yes,
join
sir,
at
sure, sir.
9:50.
Yes, sir. Thank you,
Thank
sir.
you so much, sir,
Okay,
for joining us
thank you,
today.
Amol. Thank you,
Yes, sir.
thank you,
Yes,
thank
sir.
you, thank you.
Yes, sir.
Yes, sir. Now I request our IIT Raigad President, Dr. Vikas More, sir, to welcome the dignitaries, experts, and presenters.
Thank you so much, Dr. Neha. I am Dr. Vikas More from IIT Raigad. Journal journey is a legacy which I am carrying on my shoulders, given by my seniors, and I am so proud of it. And this has become a movement all across India. It is evident that the experts from East Zone like Shantanu Dev sir have joined, Yogesh Parikh sir is blessing our journey. It itself gives us a significance that it has become an academic feast to be enjoyed by all the students who are want to learn new things. For this, I first welcome Dr. Yogesh Parikh sir, Secretary General, National CIIP, Shantanu Dev sir, Vice President, National IIP East Zone. He graced this occasion as a guest of honor. I'm so fortunate. We have a very eligible or very learned experts like Dr. Bharat Agrawal sir and Dr. Sandeep Kadam sir, and it is a feast to hear them as an expert. Those who haven't heard Bharat Agrawal sir or Sandeep Kadam sir, they will definitely enjoy their expert opinions after the presentation. And these two new presenters like Dr. Lisa and Dr. Sonal going to present a very expert, very important papers like effect of CT radiation on children causing risk of is there any risk of hematological malignancies? It is oftenly asked questions by parents to us. So there is a paper on that, and the second thing, as the rightly told by Shantanu Dev sir, there is a recent update on neonatal resuscitation 2023. At last, respected Ram Gopal sir is blessing this journal journey, and he has increased the Zoom capacity to 500 delegates. That is, thank you so much for that. And it is well assisted by Dr. Amol Pawar sir, who is so kind to Raigad IP all the time. My best friend Jitendra Gawane is present, who is always behind us for all the activities. And I will not miss this opportunity to invite all of you for the upcoming Mahaneocon conference in coming June 2024 at Vashi, Navi Mumbai. So it will be academic feast for all of you. So we have released the brochure. Please register for that. And at the end, I am very much thankful to Dr. Gangulia sir, Dr. Jay Bhandarkar sir, Dr. Chitra Kulkarni madam, and at the end, our own respected Dr. Niman Murthy sir, for all their hard work, and coordination, due to which we are having this activity continuously, despite all the hurdles. Thank you so much for all your assistance. Over to you, Dr. Neha.
Thank you so much, Vikas Modi sir. Now I request Dr. Jay Bhandarkar sir to introduce our first expert and the first presenter. Over to you, sir. Jay sir.
Yeah. Thank you, Neha. I have good evening, everybody, and I have privilege to introduce our first expert, Dr. Bharat Agarwal sir. With long CV, but I will read it very short. He's a professor emeritus of former head of the department of pediatric at Wadia Children's Hospital, Parel, Mumbai. He's the past chairman of WHO chapter of IIP 2004 to 7. Honorary General Secretary of the International Society of Pediatric Oncology. Also honored awards, many publications, and he's invited as a guest lecturer of many national, international, state level workshops. So welcome, Bharat Agarwal sir, and thanks for accepting the invitation to join as an expert for today's Journey Journal. Thank you.
Thank you very much.
And our first speaker is Dr. Lisa Balsara. She's from MD Pediatric and she's concerned pediatric and oncologist from Jupiter Hospital, Pune. And she's going to talk on the very important topic. So welcome to Dr. Lisa for this important academic piece.
Thank you, sir.
Over to Neha again.
Dr. Lisa, you can start sharing your slides.
Good evening, everyone. I'm Dr. Lisa Balsara. I'm a consultant pediatric hemato-oncologist and a BMT physician, Jupiter Hospital, Pune. And I thank Maha IIP and all the seniors for giving me this opportunity. And it is my privilege to present one of the most interesting topic, risk of hematological malignancies from the CT radiation exposure in children, adolescent, and young adults. And the expert for the session is our mentor, Dr. Bharat Agarwal sir, who is the former professor and head of consultant of pediatric hemato-oncologist, Wadia Children's Hospital, Mumbai. So this article was published on 9th of November 2023 in the journal Nature Medicine. The impact factor of the journal is 82.9 and the immediacy index is 21.3. Why this article was selected? Because there was an emerging trend of rapid increase in leukemia in compared to all the cancers. As you can see, all cancers are increasing, but the leukemia is, in comparison with the solid organ cancer, is increasing leaps and bounds. And it was seen that the incidence of subtypes are also increasing, with ALL and AML being more, and death is remaining constant like how it was in 1988 till 2018. So was this the same ratio for the pediatric cancer? Yes, for the pediatric cancer also we found that the incidence of pediatric cancers are also increases as we are going ahead. Of course, the diagnosis is better and we have a better awareness. But in this scenario also, what we found was the leukemia, the blue part and the orange part, which is the lymphoma, consist more than 80%, or rather I say 60 to 70% of the overall pediatric cancers in compared to solid organ cancer also. So there were a lot of genicity causes and there were a lot of dilemma regarding the increase. But the nemesis of the whole crux of the story of today's presentation is this article, which was published in 1952. which studies the incidence of leukemia in survivors of atomic bomb in Hiroshima and Nagasaki in Japan. Obviously, the dose of the radiation during the atomic bomb was very, very high. But this study shows that the incidence and death rate of leukemia in 1948 and 1949, and when in the exposed radiation effects of atomic bomb, which was in 1945. They also studies the effect in the exposed population by the distance from the hypocenter. The data shows the increase in the incidence of leukemia in the total exposed population compared to the non-exposed population of the hypocenter. In this also, acute leukemia and myelocytic leukemia have been predominant, and the distance from the hypocenter didn't matter. Now, based on these studies, we had to see that in comparison with the atomic bomb dose, the X-ray and the CT scan dose is 77 microgyre to 55 microgyre in pediatric doses. Just to understand this, when we do an X-ray, the conventional X-ray is 0.02 microgyre, and even if we do the whole abdomen X-ray, the microgyre is 1. Whereas when we do the CT abdomen, the microgyre is 10. So this is just a comparison of the radiation dosimetry, which is not uniform everywhere. So, and of course, the growing practice, this is beyond before the COVID, when it is quadrupled, when the CT scans have been quadrupled over the years, and this is the double amount of it after COVID and during COVID. Now, this is an article which was published in Lancet 2012, which studies the radiation CT exposure with subsequent risk of leukemia and brain tumors. This was a very small scale center study, and it was a very small number. So because of the unoptimum number of these cohort, this study didn't show us a very good result. Subsequent study was found in 2016, which is the relation between the CT and the assessment of the cancers. But there were a lot of biases in the original estimate risk, reanalysis of the cohort, and there was a low dose radiation of the dosimetry was not discussed. So to overcome all this, we had the study in 2023, which is European multi-centered large-scale study to determine the risk of hematological malignancies from the CT scan. And it also aims to address the criticism of the previous studies related to those statistical power and potential biases. The size of the study, the cohort was 10 lakh population, has considerably increased the statistical power compared to the previous national studies. So this study is coordinated with an international agency for the research on cancer, which is ARC, which was overcome to limitation of the previous national studies and to direct estimate cancer risk from the low dose radiation CT scan in childhood and adolescent. So this has 9,48,000 individuals who went under CT scan before the age of 22 in 9 European countries. The radiation dose, which is active bone marrow site, during the whole PPT, it will be known as ABM, was estimated on the basis of the body part scan, patient characteristic, time period, and inferred CT technical parameters. So as we can see, that there were 876 individuals who underwent 13 lakh CT scans and were followed up to 2 years. So they contributed around 68 lakh person years of the follow-up. In this, 790 hematological malignancies were found, in which 578 were lymphoid malignancy, 203 were myeloid malignancy, and acute leukemia. The mean follow-up was 7.8 years. 51% of the cases were diagnosed before the age of 20, and 88% were diagnosed younger than 30 years. Distribution of the age skewed to 33% when the first CT scan was done more than 15 years of age. The distribution also varied in the outcome, where 70% of Hodgkin lymphoma and 46% of non-Hodgkin lymphoma were found in the cases when the CT scan was done more than 10 years of the first CT. The first CT was done at the age of more than 10 years. 62% of mature mature T and NK cells, and 24% of precursor neoplasm. And this also includes the myelodysplastic syndrome and myeloproliferative neoplasm, which is 65% if the CT scan was done in a little adolescent age. The radiation dose to the active bone marrow site also positively skewed. Most individuals had received a very low dose. The mean was 15.6 and median was 10.7. And on follow-up cases, 20 microgyre and 13 microgyre among the cases. The most scanned part, 80% was the head part, 40% is chest part in newborn, and 56% abdomen in the adolescent age group. Number of CT. As the basic CT number, the reference category was 1 CT, there was an increasing trend in relative risk was observed when the increased number of CT scans were done for both hematological and myeloid malignancies. In continuous analysis, the risk increased by 43% per examination of the CT for hematological malignancies overall, 42 and 48 respectively for lymphoid and myeloid malignancies. So if we are doing repeated CTs, the risk increases for the malignancies, as per shown in this figure. So this study was conducted to directly estimate the risk of CT radiation doses received in the pediatric population. The risk estimates for an atomic bomb survivors were lower than those in our studies. Very paradox this thing. Thus, despite of unavoidable differences in the dose, our results suggest that the linear no threshold model does not overestimate the risk of pediatric CT radiation. Our leukemia risk estimate is compatible with those derived in a recent combined analysis of the data on individuals exposed through this radiation before the age of 21 and the active bone marrow dose. The conclusion for our study was, large scale study, we needed to put the direct evaluate cancer risk from the pediatric young adult study radiation. Thus, we need to raise awareness in the medical community and continue the strict application of all the radiological protection with justification and optimization of the radiological procedure in the pediatric population, and definitely ensuring the benefit to risk ratio is maximized for all CT examination. Thank you.
Thank you, Dr. Lisa. Now, may I request Bharat Agarwal sir to give his expert comments.
Thank you, Dr. Lisa Balsara, for a very brief presentation of the paper, but covering all the salient points. And I think this is very important from our practice point of view. So I would pose 2 questions here. What's new from this study for us to learn, for all of us? And number 2, what are the lessons that we take home today from this study? You know, these are very important questions to answer for us. Dr. Lisa has touched upon this. Maybe some points I may be repeating, but it's worthwhile because we need to go home with a very clear message on what this study implies. So first question, what's new? The first thing that is new is that it's the largest study. You know, 1 million children has never been followed up in such a manner. And it's a multi-center study, multi-nation study covering 9 countries. So you can't really fight with the data. It's really crucial to understand that this is not something that is very easy to deliver this kind of study. So we can definitely consider this as a robust study. And what is already known is that moderate to high dose radiation is an established risk factor for hematological malignancies, as Dr. Lisa pointed out from the atomic bomb study and several other studies. So ye to malum hai, this is known, you know, that moderate or high dose. Now, what is moderate dose? She did not highlight that, but I'll inform you. Moderate dose is anything more than 100 microgray. And large dose is more than 500 microgray. So we are not talking about those doses. CT scan is around 8 microgray. She did put up a slide earlier, but just for refreshing, it's around 7 to 8 microgray. So we are talking about low dose radiation, and here lies the confusion. Low dose radiation mein cancer badhta hai kya? That is the question. So this study definitely answers that question. They have studied 1 million children. The cumulative dose correlates with the risk. There is an excess relative risk of around 2 per 100 microgray. So now 100 microgray means around 10 CT scans, not 1. But still it is increased. And this translates to about 16% increased risk with an average bone marrow dose of 8 microgray for a typical exam. So in simple words, if I have to say, with an average bone marrow dose of 8 microgray, which is used for a typical CT scan, it translates to a 16% increased risk of cancer, which is 1 in 5, so it's quite significant. So even suppose I always think myself and my family, if I have a child in my family, would I expose him to a CT scan? No. I mean, I would think twice before sending for a CT scan. Now here, a distinction should be made that CT scan of head, chest and abdomen, these are more relevant than CT scan of extremities. CT scan of extremities are more or less less dangerous, I would say, and especially this study also proves that. So it's either the head, that means the skull, or the spine because of the chest or abdomen exposure. So these are dangerous ones. These one should think, and I'm sure when you go into the depth of the study, when especially neonates are exposed, there is definitely more chance of a hematological malignancy coming up a little later. So this is about the incidence. If you take it in another way, the article describes this, that for every 10,000 children with a mean dose of 8 microgray, 1 to 2 persons are expected to develop a hematological malignancy attributed to the radiation exposure in the subsequent 12 years. So it's not very far away. The malignancy can happen within 10 to 12 years. And the chance is 1 to 2%, average 1.4, they say, but I mean 1.5. So it's quite a significant incidence of malignancy. So my second question then, what are the lessons for us? What do you take home as message tonight? The first is that your radiologist who's doing CT scan must optimize the doses and try to reduce the exposure. So as I already mentioned, extremities don't carry so much risk, so that's not a problem. But if you're doing head or chest or abdomen, you have to definitely take care that the radiologist is careful and dosages are kept as low as possible. It's also possible to monitor what dose is delivered. It's also possible to follow strict radiological protection measures for the baby so that exposure is minimized. So these are the measures at the end of the radiologist. What does a pediatrician do? Order for scans only when justified. I mean, without proper indication, jara chalo dekh lete hain, aisa attitude nahi chalega. We have to be really sure of why we want a CT scan, and unproductive exposure should be avoided. We have to, as Dr. Lisa mentioned, ensure the benefit to risk ratio is maximized. We must get at least some results out of our scan. Just for screening purpose, a CT scan should not be done. So that's my take-home message. I think I'll end there and wait for any questions if there are. I would suggest if there are questions, let them come now, because for the second part of the meeting, I'm not likely to wait.
Yes, sir. The basic thing is that does the contrast increases the risk?
Contrast is not related to radiation exposure. We are only talking about radiation exposure. So it is the mechanism we must understand. It's that the radiation is the culprit. And therefore, with MRI, we don't have a problem. It's only with CT or X-ray where there is radiation. So radiation is exposed, and radiation is hitting what? Not the bones, the bone marrow. The bone marrow in children, where is it? It's in the central bones. The long bones, bone marrow takes time to develop, and therefore CT scans of the extremities are not a problem. So CT scan of the head, chest, abdomen, where the bone marrow is sitting. That is why the bone marrow is the site of production of hematological cells. And when it is hit with a radiation, then the hematological cells undergo a cancerous change and lead to either a lymphoma or a leukemia. So that's the mechanism. Contrast is nothing. Contrast is a chemical which you're just using for enhancing the radiological picture that at the most may have renal effects, not effects on leukemia.
And the duration also may increase.
Yes, the duration of the scan, Dr. Lisa already pointed out, that the more the number of scans, the more the chances of malignancy. The relative risk increases with each scan. So follow-up scan, abhi theek hai, nahi hai, dekhna hai, all that can be easily avoided,
Yes. Sir, the second question is that apart from pediatric, which other fraternities should be informed about this issue?
See, this study is limited to pediatrics, but I'm sure that whenever bone marrow is exposed to radiation, same effects will happen with whatever age group. See, bone marrow is just a factory of blood cells. You are hitting the factory. Whether it is a neonate, whether it is a child, adolescent, or adult. There are, in this study of 10 lakh people, there are adults also. It's not just pediatrics. There are adolescents and adults. Those also have been affected. So your answer is already provided.
Yes, sir. Over to Dr. Neha.
Yeah.
Madam, there were some questions in the question box. You can
Yes, sir.
just see
Please
and
ask,
ask.
because sir will not be available till end.
So
Please
you can
ask.
see, madam, you can see the chat box.
Dr. Neha or Dr. Pallavi? Pallavi, ma'am?
Yes, ma'am. I'm here. Checking.
Yeah. Please share the chat box question.
One question is from Dr. Pramod Wankade, sir. He has a question. High resolution has the additional radiation?
Yes, definitely. The exposure will be more, and it will definitely, but we have to measure, as I said, one of the pointers is monitoring the dose that is delivered. So there must be some mechanism at each CT scan center to monitor कि मेरा machine से कितना dose जा रहा है. That I think we never ask the radiologist, and we never even bother. So now we have to bother first with the child कि मैं इसको भेजूं कि नहीं भेजूं, और भेजने के बाद में मैं रेडियोलॉजिस्ट से बात करूंगा कि भाई तेरे मशीन से कितना डोज निकलता है.
Sir, one more question is from Dr. Raj Kishore. In this study, and for the presenter also, whether in this study, did they analyze indication for CT in the first place?
I have read the paper thoroughly. It is a retrospective study. This is not a prospective study. Retrospective means they have just gathered the data from various sources and analyzed it. So the indications they have looked at, but they could not find correlations like that. With the number of CT scans, they have found correlation. So basically, if you see about indications, extremity scans have not resulted into any problems. So if you think that is the indication, for any tumor in the extremity, or any fracture or whatever else pathology in the extremities, there is no problem. When you hit the skull or the spine, which is the location of your bone marrow. So it's not the bone, it's the bone marrow. Remember, you're hitting the bone marrow. You're disturbing the hematological or hematopoiesis.
Yes, sir.
Yeah,
Yes.
very
Those,
strong take-home message from sir.
Yeah. And hematopoiesis is, these young cells which are multiplying rapidly. So that is why they get hit. See why? Only if you remember from your general pediatrics, it is only rapidly multiplying cells. When you give chemotherapy, why there is hair loss or mucositis? Because or thrombocytopenia, neutropenia, because it's all rapidly multiplying cells which are their growth is halted. So you get hair loss, you get mucositis, you get neutropenia, thrombocytopenia similarly. So this is a low dose radiation. Thrombocytopenia, neutropenia नहीं होता है, but वो hematopoiesis का तो राडा हो जाता है.
Yes, sir.
Over to Dr. Neha.
Yes, ma'am. Dr. Gangulia sir, any more questions? I cannot see any more questions. And Dr.
No. Carry on.
Yeah, so I am going to say goodbye to all of you. Good night. Thank you for inviting me. I hope I have contributed to your session. And I really like that you're running this program for 2.5 years. I can see almost 300 members. I'm delighted that this is so successful. Thank you very much for inviting me.
Thank you, sir.
so
Thank
much,
you.
sir, joining us today. And yes, and now I request Dr. Vikas More, sir. Vikas, sir, are you there? He is our second expert and presenter.
Please share the slide. Dr. Sandeep Kadam, a popular personality in neonatology circle, is from KEM and MGM Hospital, Pune. Needs no introduction. He gives very clear concepts and take-home messages in his academic personalities. Welcome, sir.
Thank you, madam.
Our second presenter is Dr. Sonal Ghule. It's a young, talented and fellow in Wadia Hospital PICU and assistant consultant in PICU Nanavati. Dr. Sonal, can you please share your presentation?
Dr. Sonal?
She had just called me. I think, is there any issue that we have to find out?
No, she is there. She is there. She is seen, but yes, she is coming.
Yeah, thank you.
Dr. Sonal, we cannot hear you.
Audio.
Hello.
You can rejoin. Yes.
Okay.
No.
No,
Yes.
we can hear you. We can hear
Actually,
you.
ma'am, I'm not able to share. The host disabled. I mean, you need to.
Okay.
Just a minute, ma'am.
Can
Just
I
a
do
minute.
that? Yeah.
Yeah, please try again, ma'am.
Yes, ma'am. Yeah.
Yeah, please go ahead. Thank you.
Thank you so much, ma'am. So good evening, everybody. Thank you for inviting me for this presentation. And the first presentation was very wonderful. So, so good evening, everybody. So I have a topic which talks about neonatal resuscitation guidelines and few updates which are done in that guidelines. So the journal from which I've taken this article is AHA AAP Update Neonatal Resuscitation Guidelines, Medscape, November 2023. Myself, Dr. Sonal Ghule, and the expert is Dr. Sandeep Kadam, KEM Hospital, Pune. So why we have selected this topic? So usually in cardiac arrest, adults, the heart is not normal, and that leads to cardiac arrest. In pediatrics and especially neonate, we're talking about, In them, there is respiratory failure, which leads to cardiac arrest. So in neonates, the heart is normal. And so that's why we require positive pressure ventilation to inflate those sad looking alveoli in order to get that oxygenation going. And then, the child gets better and starts getting pink, and then alveoli also they smile. So the aim of this was to provide an additional details to the existing guidelines of neonatal resuscitation that could lead to changes in some practices in various cities. Settings like, we are not just talking about metro cities hospitals, we're talking about peripheral hospitals also. So in 2023, ILCOR, that is International Liaison Committee on Resuscitation, updated the previous guidelines. So mainly we are going to talk here about TPs resuscitator, supraglottic airways for positive pressure ventilation, and delayed cord clamping and umbilical cord milking. So quickly we'll summarize what NRP 2022 guidelines said. So pre-birth questions, whenever we reach any delivery labor room or OT, we have to quickly ask these questions: gestational age, risk factors, umbilical cord management, and amniotic fluid. So delayed cord clamping is about 30 to 60 seconds after birth, and which is preferred over immediate, which is around less than 30 seconds. So, but there are few situations where we do have to do early cord clamping and we cannot wait for the delayed one. So those conditions are abruptio placenta, bleeding placenta previa, vasa previa, cord aversion, RH incompatibility, HIV positive mother, and any neonate who requires resuscitation. So it also talks about routine suctioning for crying baby is not indicated. And even if we are doing suctioning, if it's required, then we do mouth suctioning before the nose. Oxygen supplementation is only needed if oxygen saturation is below the target range. And if we are giving positive pressure ventilation, then it is different for term and preterm. In term, we have to give positive pressure ventilation with 21%, that is with air. And in preterm, 21 to 30% can be given in less than 35 weeker neonates. Quickly, we'll see the NRP protocol. So we have term gestational, breathing or crying baby, good tone. So these questions we'll ask. If the questions are all yes, then we give the child to mother. Then again, warming, we'll clear airway if necessary, drying, and we'll keep on visiting that baby. Then if the answer to these questions are no, then we'll have to warm the baby, clear airway, dry, and stimulate. Then we'll look for heart rate. So if it's less than 100 and the respiration is not there, or the child is gasping or apneic, then we'll have to start with positive pressure ventilation. And we'll of course attach SpO2 monitor. Heart rate is still less than 100, then we'll have to do positive corrective, ventilation corrective steps, which are MR SOPA, which we'll talk about later. Heart rate, if still less than 60, we'll have to consider intubation. And then if it is still not coming up, then we'll have to talk about giving adrenaline. So, and on right side, you can see the targeted SpO2 after birth, 1 minute, 2 minutes, 3 minutes. So we did not even try to overcorrect it if the child is not getting saturation up. So why the delay? Actually, this is not the delay. The person is in hurry to so the doctors are in hurry, and definitely not the pediatricians. The gynecologists are in hurry. And we have to tell them that if they don't have time really to wait and do either early or late cord clamping, they can literally do cord milking. Now, 2 days back, I had a session with Dr. Mohanty. He told me how to do it actually. So then I'll actually tell you how to do it. So the placental end, you have to hold it on your left hand, and then you have to use your 2 fingers only. You'll have to squeeze it from left to right and from up to down, and then you squeeze it once and you release this pressure, because we want that placenta to refill the cord. And it happens again, you squeeze it and then you do it 3 times, and then, and then immediately you can cut the cord. So it is as good as delayed clamping. So I just answered how to do intact cord milking. And the reasons they hurry is because there is a risk of hyperbilirubinemia and hypervolemia. But again, in preterms or in babies who land up in NICUs, we does require those blood we do a lot of blood sampling, and they may require blood transfusions. So we really have to get that blood inside that baby. So delayed cord clamping. So we'll talk about advantages. So again, as I said, reduced need of medication to support blood pressure after birth, requires fewer blood transfusions. It improves survival and obviously improves neurodevelopmental outcome in those neonates. So delayed cord clamping more than 30 seconds, it's actually 30 to 60 seconds. So in which patients we can do, and if not delayed cord clamping, then what other options are available? So term, late preterms, that is more than 34 weeker, and preterm newborns less than 34 weeker, who do not require resuscitation. So we can go for delayed cord clamping. Second point is term, late preterm newborn infants more than 34 weeker who do not require resuscitation. In those, intact cord clamping is not beneficial compared to delayed. So the preferred one is still delayed in those kids. And then for preterm newborn infants between 28 to 34 weeker gestation who do not require resuscitation, in whom delayed cord clamping cannot be performed. So there we do quickly intact cord milking and go ahead with the resuscitation. Then for preterm newborn infants less than 28 weeker, intact cord milking is not recommended. And for non-vigorous term and late preterm infants 35 to 42 weeker, intact cord milking may be reasonable compared to even early cord clamping. Forget delayed one. So here we will consider intact cord milking. So now this we covered the first part. Now we'll try to talk about positive pressure ventilation. So positive pressure ventilation, as we saw in NRP, the heart rate doesn't come up, child is gasping or whatever. So you start positive pressure ventilation and then you see the response. So chest compressions, they come little later. So indications are apneic gasping baby if doesn't respond to initial steps of stimulation within the first minute. So first golden 1 minute ka rule. If heart rate is less than 100% or if child has labored breathing or oxygen saturation cannot be maintained in that target range as we saw previously. So if we are giving positive pressure ventilation, we need to see if we are giving it correctly. And if you're giving it correctly, then we should see the rising heart rate. And if we don't see that rising heart rate, despite giving positive pressure ventilation, we'll have to go for corrective steps, which are MR SOPA. So we'll have to readjust a mask. Then we have to readjust the head position, airway, we have to open airway, then suction, then open mouth. You may have to increase pressure. So maybe you're placed mask correctly, but the pressures are not adequate. So you may go up on pressure. And last is artificial airway, which is despite correcting all these steps, if heart rate doesn't come up, then we'll have to intubate the child as well. So types of resuscitation devices are self-inflating bag, flow inflating bag, and T-piece resuscitator. So here we'll talk about T-piece resuscitator. Doctor, as Mohanty asked me that we have to show them that how to actually use it rather than just talking about it. So I arranged few. So T-piece resuscitation also requires some preparation time for setup. So other like self-inflating bag and flow inflating bags. Flow inflating bag will require some setup time, but self-inflating bag won't. So similar to the flow inflating bag, it requires compressed gas source and adjustment in the dials of controlling PIP and PEEP. So this is a little bit of more work while using T-piece resuscitator. Main thing is that it gives you it provides more consistent pressure with each breath because we're able to set that PIP and PEEP. So that has an advantage over self-inflating and flow inflating bag. And what we require is effective face mask seal. So now this is T-piece resuscitator, and this is a mask which we are going to place it on the baby's mouth and nose, and the other end will be connected to those machines, maybe Neopuff and all. So once we occlude this point, it provides that breath with that PIP and with that set PIP and set PEEP. So once you remove it, it's like expiration. Once you give it, it's like inspiration. With this you can decide. With this you can decide the time for which you can give that breath. So it gives you good consistent pressure. You want to give it a little longer, you can continue pressing that. So an effective face mask seal is indicated in observing stable. So if you have a good seal, then that Neopuff for that machine will show you the stable reading. in addition, the user may not become fatigued because you're not squeezing a bag like self-inflating bag. You're just standing, you are just placing this mask, and all you are using is your one finger. So you can go on like this for a till you arrange your invasive intubation. The inflation, as I said, the inflation time can be increased if needed by occluding the hole on the T-piece cap for a longer period of time. So this can be used for CPAP, PEEP, and if it's all done and your child is paying, but you require some amount of oxygen, you can still keep like this. And the free flow of oxygen will go to that child till you either you shift that child to NICU or for further treatment. So you can use this for a free flow oxygen also. So now disadvantages. So it requires compressed gas source and adjustment to the dials controlling the PIP and PWP. So doesn't work. You have to have a self-inflating bag by bedside. An effective face mask seal is required to deliver required PEEP and CPAP. So if we are not able to do it, then it's of no use, It will be just a waste of time actually. So now we'll talk about laryngeal mask. It's also called supraglottic airway. The laryngeal mask makes a better seal. So this is a laryngeal mask. I'm sorry, this is a very large size which was available to me. So laryngeal mask makes a better seal than a face mask and may improve the effectiveness of a ventilation. Actually, before that, I would like to show you one video so that you'll understand what I'm talking about.
How to insert the pin. So this is the mask. First, we should deflate it. How will you deflate it? Attach the syringe over here and remove the air. So I have deflated the laryngeal mask. So now it is. Now insert. Remember the.
ये माझे ब्लूटूथ स्पीकर ले आते हैं.
And close part over there. And insert the contour of the mouth and insert till you feel the resistance. Inserted again, inflate the rim of the mask. Then attach the ambu bag and give the breathing. 3, 2, 3. 3, 2, 3.
So as we saw this, so this is the laryngeal mask. So this part will go inside the mouth and the pharynx and the upper airway. This will be attached to either it will be attached to ambu bag. So the way the lady showed us how to put it. So so this part should go this part should be upwards. So it should touch your hard palate and it should go inside like this, and anybody can put it. So we did not see cords, it's going inside or what's happening. So you deflate this thing, you just insert it blindly, and the moment you have resistance, you stop, you don't force it through, and then you inflate it. It's all they're all numbers 3 and all. So you use it and you put some air in this, and so what happens once you put air, this gets inflated and it comes out little bit. So don't get scared that it's coming out and not. It bulges, it comes out and it stays over there, and then you attach ambu bag to this and you can do it. You can give breaths. So laryngeal mask makes a better seal than a face mask and may improve the effectiveness of ventilation. Unlike endotracheal intubation, no instruments are required to insert. No need to visualize the baby's vocal cords during insertion. If the baby cannot be successfully ventilated with a face mask and intubation is unfeasible or unsuccessful, a laryngeal mask may provide a successful rescue airway. Now, of course, there are disadvantages with that. You cannot use it in a very small newborn. So late preterms, yes. And there are no studies about suctioning secretion from airway. And if the child is very bad, like MSL, sometimes RDS, and if you require higher pressures, so we cannot ventilate this child on this with higher pressures, because then air leaks through the seal actually. So low to moderate pressures, yeah, it works, but higher pressures you have to go for invasive ventilation. And again, one more thing is that intratracheal medications may leak from mask into the esophagus. So again, while giving it, we have to make sure that it goes actually in the trachea. So now the changes in ventilation which are being given in that updated NRP guidelines. So effective positive pressure ventilation is a priority in newborn infants who need support after birth. Use of TP's resuscitator for providing PPV, which may be particularly helpful for preterm infants, and the use of supraglottic airway as a primary interface to deliver PPV. Use of a T-piece resuscitator to deliver PPV is preferred to the use of self-inflating bag. We just saw why. And we have to keep self-inflating bag as a backup for both of them, which requires compressed gas source. And supraglottic airway preferred over face mask to administer PPV in more than 34 weeks. So again, in very preterm bachus, we can't use that. So now this is a take-home message for everybody. So people who work in good setups, people who work in peripheries. So if child doesn't require resuscitation, delayed cord clamping is beneficial over early. So you can wait for 30 to 60 seconds rather than less than 30 seconds. So we have to be just patient. Child is crying, doesn't require any resuscitation. All we have to do is hold that baby there in that position before cutting that, before clamping that cord. So which can be done in a setup at peripheral hospitals. And and if you're not able, the child is not good, not crying, then we just learn how to do that intact cord milking. So you just do that and then clamp the cord and cut it and hand over that baby to the pediatrician. So we learned about today is PPV neonatal resuscitation, delayed cord clamping, and intact cord milking. And we talked about two airways, supraglottic airways and T-piece resuscitator. So there are a few points which are given actually in the article that now in this lecture, I think we have a lot of pediatricians, general practitioners, I think neonatologists, a lot of budding people, getting into practice, already in practice. So I want them to take these points home and, do research about it so then we can come back again with good updates later on. So the 10 points, please bear with me. So optimal management of the umbilical cord in term, late preterm, and preterm infants who require resuscitation at delivery. Longer term outcome data such as anemia during infancy and neurodevelopmental outcome for all umbilical cord management strategies. Third point is cost effectiveness of T-piece resuscitator compared with a self-inflating bag. So we'll have to see now which one cost how much. The effect of a self-inflating bag with a positive end expiratory pressure valve on outcomes in preterm newborn infants. Comparison of either a T-piece resuscitator or a self-inflating bag with a flow inflating bag for giving PPV. Comparison of clinical outcome by gestational age for any PPV device. Comparison of supraglottic airway devices and face mask as a primary interface for PPV in high resource settings. The amount and type of training required for successful supraglottic airway insertion and the potential for skill decay. The utility of supraglottic airway devices for suctioning secretions from the airway. The efficacy of a supraglottic airway during advanced neonatal resuscitation requiring chest compressions or the delivery of intratracheal medications. Thank you.
Sir. Sandeep Kadam, sir, your comments, please.
Yeah, I think wonderful presentation by Dr. Sonal. We have been learning NRP for years together. There are recommendations given by the ELCOR every 5 years, and these protocols keep on changing. We also need to remember that when we are talking of neonatal resuscitation, it is TABC. So temperature, airway, breathing, circulation. So we need to keep our babies warm. Ventilation, that is positive pressure ventilation.
Sir, we are not able to get the whole words completely. Will you please increase the volume?
I've already increased, madam.
Yeah.
Am I audible now? So
sir, you are audible, but volume is too low.
Positive pressure ventilation is the key step in terms of neonatal resuscitation algorithm or program. And when we are talking of newborns, it is TABC, temperature, airway, breathing, and circulation. So Dr. Sonal wonderfully has presented everything, all the changes that we have learned. We also need to remember that there are few things. One, delayed cord clamping is very important. So in all babies, we need to emphasize and tell our obstetricians that we need to wait for about 30 seconds before we clamp and cut the cord. And it has been shown that there is reduced anemia, better iron stores, better neurodevelopment. I think that's a very important step. Number two, whenever a baby is not breathing, gasping, or apneic, we need to start positive pressure ventilation at the end of 60 seconds. That's a very important step. So golden minute. And when it comes to giving positive pressure ventilation, the new algorithm, new changes that have been recommended is use of T-piece resuscitator. And why T-piece, as already emphasized, that it gives PIP and it also gives positive end expiratory pressure, which in turn prevents the alveolar collapse or alveolar atelectasis. So that there is better lung recruitment, and that is very important. The next change that they have already emphasized is that we need to have a backup self-inflating bag which should be available in case the compressed gas or oxygen supply is less. Then we need to have a self-inflating bag which should be readily available in our resources. Otherwise, the baby might suffer from hypoxic injury. It also has been emphasized that we need to use supraglottic apparatus for giving positive pressure ventilation. Now, to this, I think we are still not geared up in terms of using our laryngeal mask airways in our day-to-day practice, because we are all very comfortable, convenient, and confident of using face mask or giving positive pressure ventilation. So this is something which probably we may take time or more research in our own countries, because policies coming from West and its implementation in our setup, I think it still needs a lot of time. We need to have our own local research before we start executing and implementing these changes. And very important word that we need to remember is that please use oxygen as a drug. Don't give oxygen rampantly in all babies who are depressed at birth, because you are going to cause more harm than good. And today we know that room air is better than 100% oxygen. And in preterm babies, we should not use more than 30% FiO2 for neonatal resuscitation. I think these are very important key steps when it comes to using our NRP or neonatal resuscitation in our day-to-day practice. So I think with if there are any questions, we are happy to take those questions, both Dr. Sonal and myself.
Yes, I could see Dr. Minaj sir also. We can request him to give his comments on the paper.
Well, good evening, all. I joined a little late when the Sonal was half through, but I could guess the feeling that she has really worked hard and put up her mind and heart together. So, all in all, she presented well. And Sandeep has always been he summarized very well. We must make it practice for a couple of things. One of the important thing is really in practice, we really not doing the delayed cord clamping. So we really have to have delayed cord clamping, number one. And of course, oxygen as a drug. I always see in my NICU, I go and see the saturation SpO2 100%. We don't want 100% saturation for newborn. So as the moment you have saturation more than 96 and above, come down in the SpO2 as your oxygen as early as possible. People tend to, there have been cases where the executive authority have seen the nursing records and having 100% saturation, and people have been penalized. So we don't want 100% saturation, not on the monitor and as well as in the record. That's very important thing. And with regard to TPs, yes, every newborn facility must have TPs resuscitator. It is very economical, very cost effective, easy to use, and very useful. In fact, TPs resuscitator is equal to start of CPAP in delivery room. So these three things are extremely important. And of course, for supraglottic devices, as Sandeep has rightly said, we need to have our own learning curve, because it's a tool which is very useful, especially in the older children. And if you see the anesthetists use it very well during their sedation in MRI room. So we need to, our pediatricians so far, and as also as the neonatologist, I have to start using supraglottic devices as well. Having said that, if we follow the basic NRP pathway, I think we are able to salvage and take care of many child in a very objective and scientific way. NRP is really game changing. It's a real game changer. This is from my end. Shantanu is there; he can add on.
With your permission, madam.
Yes, sir.
And so nice to see Dr. Minhaj Ahmed, my friend also. I thank Dr. Sonal and Dr. Sandeep for emphasizing and re-emphasizing one very important part is that we need to generate our own data. We as a country have so much of scope to generate our own data, which can change the guideline scenario of the whole world. Actually, we can be the leaders, whereas we always end up following the guidelines given by other countries. So that is one clarion call to everybody, so that we can generate much more data. One question which I had was in infant child resuscitation, that means CPR. We have now strongly adopted that we will be using cuffed endotracheal tubes. So is there a similar recommendation for neonatal resuscitation also?
I think when it comes to using endotracheal, see, basically, most of our babies do well even with just positive pressure ventilation.
Yes.
Number one. Number two, if we have to intubate, we are using uncuffed tubes. There are two reasons. One, the cuffed tubes are not available in smaller size.
Yeah.
Second, it might sometimes cause injury to the larynx. So that's why we are not using cuffed endotracheal tubes.
Sandeep, coming back to what is the actual recommendation with regard to use of cuff tube in the newborn? Because suppose we have at our end three and above, 2.5 is really not available. 3 and above is available. So suppose it is available, is it okay? Because sometimes we do encounter the leaks when we use the uncuffed tube. Number one. And number two, having said that, all of us will agree. I practice both neonatology and PICU. Ventilation in NICU is real nightmare. Real nightmare. It is easier to ventilate a older children than a newborn. So I to ventilate only when the child is in apnea or otherwise a very high requirement. Otherwise, we tend to avoid the intubation. So what is your take with regard to cuff tube? I mean, we are using it, but for a short duration. And 3 and above.
Yeah, thank you, sir. Thank you very much. I think what we are actually doing, we are going away from ventilation, intubation to non-invasive ventilation.
Yes. Yeah.
That's a very important step that we all realize. But having said that, if we have a baby where we need prolonged ventilation, we don't use cuff tubes because of the risk of pressure necrosis.
Yes,
that's very important thing that we avoid.
I agree.
Tubes. However, in a baby with very prolonged ventilation, sometimes you have a leak. In those cases, exceptionally, maybe one could try using cuff tubes, especially because if your oxygenation is at jeopardy.
But one message also should go like, your insure. I have seen people once intubate, they continue with the intubation for next 24 hours. I think again, this should also be like very clear.
Yeah.
Insure means removing the tube out. And if you do proper insure, we get the results in next 6 hours, next 24 hours. The problem is our own inhibition. Yeah, tube dal diya, next 24 hours nahi dekha jayega. No way. That's another. Sandeep, what is your take about this?
We are doing less invasive surfactant administration.
Yes, Lisa.
So these days we don't intubate. We just put the feeding tube, give surfactant, and continue NIV.
So you are doing with the feeding tube, right? Yeah. The Lisa catheter is there from Bygone, but it is expensive, right?
It is quite expensive. So, and I think all my residents, they're trained and they're quite experienced to put the feeding tube. So
feeding tube.
It's not very difficult.
So Sandeep, what number feeding tube we are putting? 6 or 8?
6.
6.
In smaller baby.
And the length?
In a bigger baby.
Or length is described as we do for the cuffed and all those
you
things.
Just see the vocal cord and stop at that point in time and give.
Lisa. I mean, one thing is very clear that we also in our NICU tend to, intubate as less as possible. That's very important. And if you do early CPAP, proper NRP, early surfactant, I think the need of intubation really come down.
Yes. Even delivery room CPAP in smaller babies, I think.
Yeah, that's what I was talking about, the TPIS resuscitator. Every delivery room, as much as possible, must have TPIS resuscitator.
Yes. Any questions, madam?
There was one question with regard to, I saw Wankhede sir asking about the supraglottic devices for neonatal use and preterm use. Sandeep would like to take up?
we prefer, I mean, we have very limited use of
Yes.
supraglotic devices. However, LMA that is available is usually in the size 1, and it is used only where one cannot intubate or where intubation is very difficult. In those situations, one would use laryngeal mask airways. Otherwise, routinely we are not recommending, neither are we using it routinely.
And Sandeep, you will also agree when we intubate the newborn, if we are gentle in our initial attempts, with some patients, intubations are not that difficult.
Yes, it is very easy.
The only problem is when we are hesitant and we are making the lot of attempts are there. Then we have a glottic edema. Then there is some bleeding, secretions, and then we become panicky and the difficult airway.
Yes.
Otherwise, if we are gentle with some having a deep breath within ourselves, newborn intubation is really able to do that. Chitra madam, over to you.
Yes. May I request past MAHA-IP President Dr. Hemant Gangolia sir to give his comments in general about this activity of journal journey. Gangolia sir.
Thank you, madam. No, it was great presentation, and always we love to hear Dr. Bharat Agarwal sir as well as Dr. Sandeep Kadam. As well as we are very fortunate to have Dr. Shantanu sir as a guest of honor, and very good presenters, both Dr. Lisa madam and Dr. Sonal madam. How much that knowledge percolates the periphery and the resource limited settings, I do not know. But how do it go in the small nursing home? It should work out. And still we see in a lot of PSCs, the neonates being resuscitated by the nurses. So how they go about to train the medical officers of the PSCs also. Most of them are of not of other Pati also. We see that I stay just 87 kilometers from Mumbai, but still at our PSC we do see of other Pati, and the babies resuscitated by the nurses, and most of the time it creates problem. So I raised this one of these question, and because the stalwarts of these neonatal resuscitation, Dr. Sandeep Kadam, Dr. Shantanu sir are there. So whether the guidelines as per the Indian guidelines and how do they support the peripheral settings is more important. How to go about is a thing to be is to be thought. As well as regarding this program, it's going since last 2.5 years. It started on the Doctor's Day of the year 2021, and it's going on. And we are fortunate to have Dr. Shantanu sir also. I would invite Dr. Shantanu sir also to have 2 presenters and 2 experts from his zone also for any of the month of the journal journey, and hope so he will agree to that. So we will have the interstate journal journey episodes too, and it's very kind enough that Dr. Ram Gopal and Dr. Amol has increased the Zoom capacity to 500, so a lot of people can attend to this Zoom, and it was excellent work done by, and hope so we get positive response from our Vice President East Zone, Dr. Shantanu sir, and so we look forward to the presenters and the experts from East Zones too. And you can coordinate with me or with Dr. Chitra Kulkarni madam. She's always there, so we can coordinate. Hope
Sure,
so
sir.
Dr. Shantanu sir is there, and he's
Yes, sir. Yes, sir.
to that.
Sure, sir. I'll look forward to it and I'll get back.
Yes, sir. Yes, sir. Thank you very much.
Hemant sir, I would to add one more thing. We must thank Dr. Sandeep sir because he came in one day before only. Day before yesterday we called and he cordially said yes. Did not ask anything. And it has always been pleasure to listen to Sandeep. He is very straightforward, crisp and to the point. So within a short span of time he consented, and we are sincerely thankful Sandeep for filling in the place. Thank you.
Sir.
Thanks.
Thank you very
मीना
much.
सर संदीप है ना, संदीप रायगढ़ का नाम सुनेगा ना तो नींद में से भी उठ के आ जाएगा वो.
No, नहीं sir, इतना आसान नहीं है. I must tell you, most of us are
नहीं.
engaged somewhere. Most of us are engaged somewhere.
नहीं, संदीप बोलेंगे, संदीप will agree what I said.
Yes.
Yeah. Thank you, Sandeep, for being with us.
Thank you very
And
much.
Sonal really did well. Lisa I missed, but Sonal really did well. Yeah.
At the same time, whatever I said, but Dr. Sandeep, thank you very much
Thank you, sir.
to make your 11th hour consent and available for this program and give your expert opinion.
Yes.
Thanks very much, Sandeep.
And now I request Raigad IIP editor Dr. Neha Singh to propose the vote of thanks.
Ma'am, you please do the vote of thanks. Okay.
Okay, thank you very much. It is my proud privilege.
I would like to thank Dr. Chitra
Yes.
Kulkarni. Thanks a lot, Dr. Chitra Kulkarni, Dr. Neha, for a great episode as a moderator, as well as we are very fortunate to have experts, Dr. Bharat Agarwal sir, as well as Dr. Sandeep Kadam sir, and both presenters, both madams did excellent well, Dr. Lisa madam, Dr. Sonal madam, and huge contributions or huge inputs from Dr. Shantanu sir, Vice President East Zone, as well as our dear friend, Dr. Minaj Sheikh. And also, we would like to thank the Maha AP office bearers, Dr. Ram Gopal, Dr. Amol, as well as Dr. Jitendra Gavane, CIP, EBCIP, as well as our office bearers, Dr. Vikas More as a president, Dr. Ajay Kohli as a secretary, and all the office bearers, as well as our AHA Raigad, Dr. Chitra Kulkarni, madam, and her team to grace this occasion, as well as we would like to thank all the attendees. I think so. I saw the figure of almost 200.
It was 281. At one
Thank
point.
you very much on behalf of IIP Raigad, as well as in association with Maha IIP. We would like to thank each and everyone, as well as our technical advisor, technical coordinator, Dr. Madam. We can say here doctor also because she has become doctor only for last 2.5 years. Pallavi Madam from Nashik, and as well as everybody who contributed to this. Thank you very much.